Good morning, everyone. I'm just going to wait for 30 seconds to allow everyone to get into the Zoom room. All right, welcome to Hamilton Health Sciences Department of Medicine Grand Rounds, and thank you everyone for joining this wintry, rainy morning. We're very pleased to have both Dr. Devereaux and Dr. McGillion today, who's going to speak to us about virtual care and remote automated monitoring after hospital discharge post-surgery. Can this improve outcome, and if so, how? Well, there's a lot of interest in this area. I'm just going to briefly introduce our esteemed speakers. Dr. Devereaux obtained his MD from McMaster University after medical school. He completed residency in internal medicine at University of Calgary and residency in cardiology at Devereaux. He then completed PhD in clinical epidemiology at McMaster University and worked closely with Dr. Gordon Guyot and Salim Youssef. Dr. Devereaux is a cardiologist, perioperative care physician, and clinical epidemiologist. He's the director of Division of Perioperative Care at McMaster University, and we know that Dr. Devereaux has established a lot of fascinating perioperative care standards for us. He's a senior scientist and scientific leader in anesthesiology, perioperative medicine, surgical research group at the Population Health Research Institute. He's a full professor in the Department of Health Research, Methods, Evidence, and Impact, and Department of Medicine at McMaster University. He's the president of the Society of Perioperative Research and Care. We all know Dr. Devereaux's established career. He published more than 380 peer-reviewed papers, more than 80 book chapters, editorials, commentaries. Dr. Devereaux has an H index of 102. And more than 100,000 citations. He's also supported by McMaster University Health Research and Hamilton Health Sciences Chair in Perioperative Care, and he holds the Tier 1 Canada Research Chair in Perioperative Medicine. And I'm sure that even this introduction is not did not give you a fair.
I think my mother must have written that, Khaled. Huh? I think my mother must have written that. I think. Okay.
No, I can't. I still have to read more and more, but I'm gonna, for the purpose of moving on, gonna introduce as well Dr. Mike McGillion. He's an associate professor and assistant dean of research in the School of Nursing at McMaster and the scientist at the Population Health Research Institute. He's a nursing leader of the division of perioperative care, and working very closely with Dr. Devereaux and colleagues in the post-surgical virtual care and patient remote automated monitoring studies now. Without further ado, I'm going to pass it on to Dr. McGillion, and who is also, we're going to do the land acknowledgement. Yes, please go ahead.
Well, thanks so much and good morning. It's a pleasure to be here with you all. And so we just want to start with acknowledgement that we meet on the traditional territories of the Mississauga and Haudenosaunee Nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. So PJ and I appreciate the opportunity to reflect with you today on two of our recent virtual care with RAM trials. They have important structural differences in terms of the intervention that reflect the evolution of our thinking, and we'll reflect on that as we talk. So we'll start with the SMArTVIEW trial. By way of background, annually tens of thousands of cardiac and vascular surgeries are performed in Canada and the United Kingdom each year in order to improve survival, symptoms, and quality of life. But delayed detections and complications of hemodynamic compromise and post-discharge acute hospital care are, of course, challenges. So we undertook the SMArTVIEW trial to examine the impact of a digital health intervention, which included in-hospital post-operative remote automated monitoring, or RAM, and post-discharge virtual care in RAM. So the design was an international RCT of 572 patients. Those included were age 60 and or major post-index ICU. The intervention SMArTVIEW had two major components, in-hospital RAM and post-discharge virtual care with RAM for the first 30 days after discharge. And then patients were also allocated to standard care. The setting included 2 centers, so here at Hamilton Health Sciences and Liverpool Heart and Chest Hospital in the UK, and the primary endpoint was 45 days of follow-up after randomization. So we did have a design modification. We intended to recruit a sample of 800 patients, but we needed to stop due to the pandemic. So in terms of the in-hospital component of the intervention, patients who were allocated to RAM in hospital with care had a vital signs monitor assigned to them, provided. We also applied cableless devices to the patient that tested vital signs continuously. And so this was in place of nurses doing vital signs manually on the surgical ward. And these pods communicated by short range radio to the device. Nurses would be sent nurses carried a handheld phone and would be sent a page if it looked as though patient's acuity would potentially rise. And this system was programmed according to the Hamilton Early Warning Score. And early warning scores, for those unfamiliar, are clinical prediction models that use vital signs and pre-established thresholds to help predict the likelihood of clinical deterioration. And so this system would draw early attention to care by bringing nurses to the bedside to reassess the patient if it looked like vital signs and the acuity score would rise. In terms of the hospital to home part of the intervention, once patients were ready for discharge, patients were sent home by hospital to home equipment, again provided by Philips. Patients had a tablet-based computer with RAM technology to take their vital signs and their weight. And so each day, 3 times daily, they would take blood pressure, heart rate, respiratory rate, blood oxygen saturation, and their temperature and their weight in the morning. Patients also completed a recovery survey for us, reflecting issues of common concern to patients, such as constipation or vomiting, other symptoms, to inform nursing assessment. Specially trained nurses called SMArTVIEW nurses conducted a post-operative head-to-toe assessment of the patient by a video visit daily. They would also examine the patient's surgical wound and take imagery of that photography. They also completed a medication reconciliation every 7 days in order to look for medication error that might need to be corrected. We had vital sign thresholds that were in place in order to inform escalation of care from the nurse to the surgeon or surgical resident. The SMArTVIEW nurses completed 2 important functions. They were installed right on the hospital wards. So they supported the ward staff using the Guardian system and engaged in change management to make sure that people were using that equipment for the in-hospital portion. And they also were the nurses who executed the hospital to home program. Important is that in SMArTVIEW, this was a daytime service only, functioning from 8 a.m. to 8 p.m. during the day. So in terms of baseline characteristics in the trial, we had equal numbers of patients per group. The average age was 73, 77% were male, and 95% had cardiac surgery, and 5% underwent vascular surgery. For the primary outcome of acute hospital, post-discharge acute hospital care, which included emergency room department visits, hospital readmission, and urgent care center visits, we used the Prentice-Williams conditional time gap model, which helped us estimate the overall risk of events, taking into account all events during the follow-up period. And what we observed is that post-discharge, there were more acute post-hospital events in the standard care group compared to the intervention group, but the difference was not significant. In terms of in-hospital outcomes, looking at the RAM technology, the Philips Guardian system, we were able to facilitate increased detection of patient acuity rises based on the Hamilton Early Warning Score. So an average of 2.8 increased acuity detections per patient in the intervention arm versus 0.9 in the standard care. And we were also able to see escalations of care from nurse to physician on the surgical ward, an average of 2.5 per patient in the intervention group and 0.8 in the standard care, where people were just having their vital signs taken manually by nurses according to regular hospital protocol. So in relation to acuity detection, we also saw an increased number of elevated acuity related interventions. So 2.3 interventions per patient on average versus 0.8 in the standard care group. And then we saw decreases in patient acuity score following those interventions, an increase in those, 2.1 in the intervention group versus 0.7 in the standard care with manual vital signs being taken once again. So early warning systems, the higher the score, the greater patient acuity, and we can see that the SMArTVIEW intervention using the Philips technology facilitated increased detection of patient acuity scores at various levels. We did not see an impact on ICU readmission from the surgical ward between groups in this trial. In terms of post-discharge outcomes, again, nurses were conducting that medication reconciliation, and we saw a significant increase in the ability to detect medication errors in the intervention group versus the standard error group. So you can see 112 total medication error detected in the intervention group versus 13 in the standard care group during the follow-up period. In terms of moderate to severe pain, so pain assessment was a key part of this. We did observe less moderate to severe pain reported in the intervention group versus standard care, and a greater number of pain medications for patients in the intervention group, but the differences between groups were not significant, and this reflects, and this is an important reflection that we'll talk about later in the talk. So in summary, this was early work for us in terms of RAM and virtual care, and we observed high rates of elevated patient acuity scores, so 73% in the SMArTVIEW group, where technology helped us facilitate detection of that. High rates of acute hospital care post-discharge after surgery, so 22% in the standard care group. High rates of drug error post-discharge, so 21% detected in the intervention group. And high rates of moderate to severe unrelieved pain at 45 days, so 20% in the standard care group. So in conclusion, in hospital, SMArTVIEW did facilitate increased detection and decreases in patient acuity score, and increased escalation of care and intervention at the surgical ward level. We were not able to see a difference on this in important clinical outcomes like ICU readmission, but we did have limited power to examine those outcomes. Post-discharge virtual care and RAM also increased our ability to detect medication errors, but we did not see a difference between groups in moderate to severe pain related to patients' medication. And so in terms of implications, this was an important study for us to gain experience in setting up RAM in hospital. And we need to ensure that early warning systems are set up optimally to facilitate early identification and timely attention to care. But we do need large RCTs to establish that impact on these important patient outcomes.
Okay, I'm going to now tell you about the PHRI-1 trial. Mike, I think we're getting feedback from your speaker. And again, as Mike pointed out, this was an evolution in our thinking, and there's a couple of very key design differences in PVC-RAM that I'm going to emphasize that, as you will see, have a very different result in terms of the actual outcomes. So as background to PVC-RAM-1, so early in the COVID-19 pandemic, many hospitals were canceling their elective surgeries, but the semi-urgent, that is the oncology surgery, the urgent and emergent surgeries continued. And patients discharged after non-elective surgeries based on CHI data have 20 to 25% incidence of acute hospital care, that is hospital readmission or ER visits within 30 days. So there's a very high proportion of patients that end up coming back to the hospital, and it's split between the ER and a readmission. And after hospital discharge, patients usually see their doctor in 2 to 8 weeks, and they're not being monitored in terms of any technology. This can also result in delays in recognizing and managing complications, which can lead to rehospitalization and poor outcomes, and potentially early identification and management of complications may reduce acute hospital care. So PVC-RAM-1 was a randomized controlled trial. We included patients age 40 or greater who are being discharged after non-elective surgery. We included 905 patients. These patients were evenly randomized to receive virtual care with remote automated monitoring technology, RAM, for the first 30 days after discharge, or to have standard follow-up with their physician and surgeon. We had 8 centers in Ontario and Alberta participate in this trial. The intervention of virtual care with RAM included a tablet computer and RAM technology, which came from CloudDX, which is a Canadian company. And this intervention with the RAM technology allowed us to measure patients' blood pressure, heart rate, respiratory rate, oxygen saturation, temperature, daily weight for 30 days. Patients completed the recovery survey daily for 30 days. And the virtual nurse did a call daily on day 1 to 15 and every other day on day 16 to 30 with the patients. Wound photos were taken daily from day 1 to 15 and every other day, days 16 to 30. And the centers could change. Now, to back up one point, in contrast to SMArTVIEW, where basically the nurses ran the program, and if they found a problem, they could try to contact the surgeon who was connected to the patient. In setting up PVC-RAM-1, we designated that there had to be a perioperative care physician on call 24 hours a day who was able to respond right away to the nurses and did daily rounds with the nurses, reviewing all of the cases. These perioperative care physicians most commonly did come from general internal medicine, but they also included people coming from cardiology and infectious disease, many other disciplines, and also included some surgeons. So it was a multidisciplinary group that did this. We typically did 1 week on call, where you'd be on for 24 hours a day for the week, like a week on service. And that was a very fundamental difference. Now, a key difference too was that although we set thresholds for where the nurse was to escalate care to a physician. So as an example, if the blood pressure was systolic was less than 100 or greater than 160. However, the centers or physicians could change those thresholds. And this becomes very important, and it will offer some insights as to what might happen when you allow people to alter the thresholds for alerting the physicians and bringing them into the care loop. This shows you the technology. The main point, just to say, is that with the technology, it's crucial that it's patient-friendly and it's simple to use. So this technology is all Bluetooth enabled. So when the patient puts that blood pressure cuff on their arm and they press that red button, it'll measure their blood pressure, and then it automatically uploads onto the tablet, which is cellular enabled. And then right away, that data is available to the nurses and physicians, and it will create alerts based upon the thresholds that are set related to that patient. So now when we first started the trial, our primary outcome was acute hospital care. That is ER visits or readmissions to hospital. However, the second patient that we randomized in the trial was a patient from the Hamilton General Hospital. And this patient was randomized to our virtual care and RAM technology group. And on the first day this patient went home, the patient was doing fine, their vital signs were fine, and in the interaction with the nurse, the patient was fine. The next morning, this very elderly gentleman's vital signs came up and his heart rate was 32 beats per minute. The nurse then contacted the patient back through the virtual tablet, and the wife's the one who answered. The wife was also very elderly. And the wife said to the nurse, dear, we've done the vitals because we want to, not mess up the study, but my husband is exhausted today. He tells me that he wants me just to let him sleep, and we will resume doing the virtual visit tomorrow and get back on doing further vital signs tomorrow, but I'm just going to let him sleep. The nurse appropriately escalated that care to the perioperative care physician, who happened to be Maura Marcucci, who was on. Maura then contacted the patient back and insisted with the wife that she actually see the patient. In communicating with the patient, Maura discerned that the patient wasn't simply tired, but had decreased level of consciousness. An ambulance was organized, and the patient was brought to the hospital, found to be in complete heart block, and received an emergency pacemaker. Now, this case made us recognize that if this patient, who I think most people hearing that story would say that obviously the program, did something very positive and Maura might have even, and the nurse may have even saved this patient's life, because the patient was going to be left to sleep all day and who knows what could have transpired. But this patient now was an event, for our primary endpoint of acute hospital care because the patient survived to get back to the hospital. If this patient was in the control group and the wife just let the patient sleep and the patient died and never made it to the hospital the next day or the day after, the patient would not be an event. Recognizing this problem, we then made a decision, and like a lot of decisions in research, you will gain greater insights at the end of it. We made a decision to say we're going to change the primary endpoint from acute hospital care to days alive at home, which has been an outcome that's been advocated by a number of people in the perioperative setting. And as I will show you in a moment, we would gain insights into what can be the limitation of that outcome. But that's what happened in this trial within the first couple of patients. So the baseline characteristics for participants, mean age was 63 years of age. We had a good split between men and women. 55% had semi-urgent surgery, 35% had urgent surgery, and 8% underwent emergency surgery. 81% underwent non-cardiac surgery. We had a large distribution across the surgeries with general, urogyne, and orthopedics being the largest groups. And cardiac surgery was 20% of the patients. There was one patient who had both non-cardiac surgery and cardiac surgery. Of the 905 patients that we randomized, 903 completed a 31-day follow-up, so it was 99.8% completed the follow-up. So patients saw a non-study surgeon, family physician, or specialist in person or virtually in the first 30 days post-discharge in 77% of the patients in both groups. So importantly, we didn't want to affect standard baseline care. And as we see here, it was consistent across the two groups. But it also highlights that almost 1 in 4 patients aren't seeing any physician in the first 30 days post-discharge. And that's, again, for semi-urgent, urgent, or emergent surgery. If you look at our compliance with the virtual care and RAM, so the number of scheduled visits between the patient and the nurse was 23, and we ended up having a mean of 20. The number of scheduled wound photos was 22. We ended up getting a mean of 15. And again, our learning process with this is that there's obviously many patients who even by day 10 post-discharge, their wound is fine. And so obviously as people got later on in the trial, people start to lose interest in taking daily wound pictures when in fact their wound from their point of view has been healed for a long time. The number of scheduled days of using the remote automated monitoring technology was 30. We ended up getting a mean of 24. We only had 9% of the participants permanently discontinue using the tablet or RAM before completing the 30-day intervention, but most patients, even of those 9%, were using it for several days before they stopped using it. So we had overall quite good compliance with using the technology. When we look at the outcome of days alive at home, the trial was powered to show an absolute difference of 0.2%. And that's in fact what we saw. However, the result was not statistically significant. And the one thing we learned from this is that a limitation of days alive at home is that it may work very well in very large epidemiological studies to predict, what's going to happen in terms of many things. But the problem is you become vulnerable to outliers when you have a trial in the range of 900 patients. So there'll be some patients who are going to, end up coming back to the hospital right away and staying in hospital the whole time. And this can actually influence what you see as a result. When we look at our initial primary endpoint, in the standard care group, acute hospital care occurred in 27% of patients. So it's important to note that this was once again happening during COVID time. So most patients were hesitant to come back to the hospital. Despite that, 27% of people in the standard care group came back to the hospital or were readmitted to the hospital. In contrast, in the virtual care group, it was 22%. That's an absolute difference of 5% with a p-value of 0.06, but there's much more to come about this signal in a moment. Brief acute hospital care was acute hospital care that lasted less than 24 hours. Again, we see an absolute difference of 4% favoring the virtual care group with a p-value, again, that's close to being statistically significant. If you look at hospital readmissions, 13% of people in the standard care group were readmitted to the hospital within a 30-day period. This was decreased to 10% in the virtual care group, a 3% absolute difference, not statistically significant, but again, in the direction of benefit. And in the end, when we look at the deaths and this concern about a competing outcome problem, it ended up being a non-issue anyways, because it was only 3 deaths that occurred in the virtual care group and 3 deaths that occurred in the standard care group. Looking at our secondary endpoints, as Mike had highlighted in SMArTVIEW, again, drug errors are incredibly common. So in the virtual care group, we detected that 30% of patients who went home had drug errors. And of these 30% of patients, on average, they had 2 drug errors. Whereas in standard care group, only 6% of patients during standard care are detected to have drug errors. This is an absolute difference of 24%, a result that is highly statistically significant. Equally importantly, is we demonstrated you can correct the drug errors with virtual care and RAM technology. So again, we demonstrated a 24% improvement in correcting drug errors with the virtual care group, a result that's highly statistically significant. And again, here when we look at pain at 7 days, 15 days, and 30 days after randomization, we see absolute differences of 14, 12, and 10%, favoring the virtual care group having less pain, results that were highly statistically significant. If we look at the moderate to severe pain, what we see is at day 15 and 30, if we're looking at the pain that's at its worst in the last 24 hours while lying down, we see 6% absolute differences favoring the virtual care group. And if we look at pain at its worst while moving in the last 24 hours, again, at 15 and 30 days after surgery, we see 8 and 7% absolute differences, again, favoring the virtual care groups. We see overall substantial impacts on pain, and we're also seeing impacts on the worst types of pain. We looked across all forms of medication that are used for pain medication, including narcotics, cannabis, gabapentinoids, all these different agents. The only drug that changed across time was acetaminophen. So what we see is we see a very big increase in the use of acetaminophen in the virtual care group, 52% at 30 days after randomization, whereas it was only 27% in the standard care group, a 25% absolute difference, a result that is highly statistically significant. And importantly, we're showing that we can drive down pain and moderate severe pain by being much more assertive about using the lowest risk medication, being acetaminophen, to help manage these patients' pain. We still can make further improvements, but this even shows by even doing low-level interventions, we can substantially impact pain. As I alluded to earlier, we ended up seeing striking differences across centers in the escalation of care from nurses to physicians. And this is not explained by the type of patient that underwent surgery across these centers. So Center 1, which is the Hamilton or the Jarovinsky site, 88% of the patients had their care escalated from a nurse to a physician. And at Center 2, which is the general site, 91% of the patients had their care escalated from a nurse to a physician. In Center 3, which is St. Joe's, which is quite similar to the Jarovinsky in terms of the patient population we're looking at, we only had 55% of the patients escalate their care from a nurse to a physician. And we had a very different structural setup in town across the HHS site versus St. Joe's. HHS, we brought the nurses and physician group together across the Jarovinsky and Hamilton General sites. And we had a very strict protocol with the escalation of care. At St. Joe's, there had been a program in place with nurses that have been doing care with surgeons previously, and obviously different thresholds can end up existing in terms of when people then will start to escalate care based upon prior experiences. Center 4, which had very few patients, there was again a high escalation of care. Center 5, center had only 24% of its patients having escalation of care from a nurse to a physician. Center 6 and 7 had 55%, and Center 8 only had 38% of its patients having escalation of care from a nurse to a physician. So if we then put these centers into high escalation of care centers, intermediate and low escalation of care centers, we see that in the high escalation centers, 89% of the patients have their care escalated from a nurse to a physician. In the intermediate, 55% of the patients, and in the low escalation centers, only 34% of patients. But the result is even much more than just the proportion of patients getting the escalation of care. When you look at the overall number of escalations, it is strikingly different. In the high escalation centers, this occurred in 758 times. In the intermediate, 227 times, in the low escalation centers, 56 times. So very striking different involvement of physician care across our centers. If we then look to see, what were the factors that drove the escalation of care? For certain, people set different thresholds, because in the high escalation centers, the biophysical parameters led to escalation of care in 278 patients, in the virtual care, 78 patients, and in the low escalation centers, 10 patients, or 10 times. It could be more than one for a patient. But to make the point again, this is not simply explainable by the difference in patient populations across the centers. So as an example, taking St. Joe's and the Jaravinsky, where in fact, the patient population was incredibly similar, we saw striking differences, and across other centers, we saw striking differences despite similarity of cases. And importantly, as you might guess, you also see very striking differences in management when you have the high escalation centers compared to intermediate and low. So in the high escalation centers, a change in medication happened with the patient 237 times. In their intermediate escalation centers, only 124 times. In the low escalation centers, only 24 times. And virtual visits follow a very similar pattern, where you're seeing this very substantial gradation in the involvement of physician care and the actual changes to care that can happen from this. When we then look across our outcomes at the results based upon the centers with the highest escalation of care, intermediate and low, we see very striking differences. In the high escalation centers, we see that acute hospital care, which again is ER visit or readmission to hospital, occurred in the standard care group in 32% of patients, whereas it only occurred in 18% of patients in the virtual care group. This is a relative risk of 0.56, a result that is highly statistically significant. In contrast, we see no effect in the intermediate escalation centers and in the low escalation centers. If we look at brief acute hospital care, again, we see a very striking difference. In the high escalation centers, the virtual care group resulted in a substantial reduction in brief acute hospital care. The relative risk was 0.47, a result that was highly statistically significant. And again, we saw no effect in the intermediate and low escalation centers. We look at ER visits, the exact same message. The high escalation centers, virtual care with RAM resulted in a very large reduction in ER visits that was highly significant, but we saw no effect in the intermediate and low escalation centers. If we look at hospital readmission, a similar pattern. So hospital readmission in the standard care group in the high escalation centers is 16%. In the virtual care group, it was 10%. The relative risk was 0.62. It was not statistically significant, but again, it was completely consistent with the signal we saw across all the other outcomes. And again, we did not see an effect in the intermediate and low escalation centers. So in summary, we saw high rates of acute hospital care after discharge post-surgery, even during COVID-19 pandemic, 27% in the standard care group. This has an enormous impact on just cost of care, but also given that half of those patients, 13%, get readmitted to the hospital, blocking beds and slowing our ability to deal with the backlog of patients who are waiting for surgery because these patients are blocking beds. We saw very high rates of drug errors. 30% of patients in the virtual care group on average had a drug error, and on average, these patients had 2 drug errors. We saw high rates of pain after hospital discharge, 60% at 15 days, 45% at 30 days in the standard care group. And we saw high rates of moderate to severe pain after hospital discharge, 33% at 15 days, 25% at 30 days in the standard care group. In conclusion, virtual care with RAM did not affect days alive at home. However, virtual care with RAM increased identification and correction of drug errors and reduced pain, including moderate to severe pain. And in centers with high escalation of care and management of care, we saw 40 to 50% relative risk reductions in acute hospital care, brief acute hospital care, and ER visits with the virtual care and RAM technology. Implications when you think across what we've observed and learned from PVC-RAM-1 and SMArTVIEW, we had very differences in designs where in SMArTVIEW, we didn't have 24-hour-a-day coverage with the patients. It was from 8 to 8. In SMArTVIEW, it was in PVC-RAM, it was 24 hours a day coverage. And also the really important difference is that in SMArTVIEW, the nurses, if they found a problem, were left to try to contact the surgeon again, who often is very busy doing other surgeries to see if they can correct that problem. Whereas in PVC-RAM-1, we set up a very explicit physician dyad between the nurse and physician, and there was a paraphysician available 24 hours a day, 7 days a week, who was responsible for running the service with the nurse. And so when you look at these, it appears to us that our results suggest we need a dyad of nurses and dedicated and available perioperative care physician teams. And we need daytime and nighttime coverage is essential. A lot of the patients come back after hours because they can't sort out a problem. And most fundamentally is that it's only credible to expect virtual care and RAM to impact outcomes if it identifies problems and care is changed. And so again, if we think that we'll just put technology in place and the technology will solve the problem on its own, I think that we're destined for failure. But as PVC-RAM-1 shows, if we do put good technology in place and we have a very clear pathway of who's going to address the problem, and we have engaged nurse and physician teams that do address the problem, there's great potential to see very significant impacts on outcomes. We published these results just last year in the BMJ, and just want to thank all the participating centers and investigators who made this possible, including a lot of physicians here in Hamilton who played key leading roles to make this possible. Thanks very much. I'd be happy to take any questions.
Thank you very much, Mike and PJ, on this excellent presentation and summary of what we've had in evidence so far in virtual monitoring. So for questions, please put your questions in the Q&A section. If you want to bring your question in person, please raise your hand and I'll bring you in. So there are already a couple of questions in the Q&A. So great talk. Can you describe the types of medication errors specifically and how these were better detected virtually? Seems like there's an opportunity for collaboration and support from pharmacy and colleagues. So question about medication error.
Do you want to start, Mike?
Sure, thank you. So just to start in terms of the process of detection, just to review that again, we had learned based on experience that it requires regular reconciliation and review. And so every 7 days, we undertook that reconciliation based on intent. So based on things stopped and started after surgery, what was the patient supposed to go home on? What was the intent? And we did the reconciliation based on that. What we found in PVC-RAM-1 was that the most common form of drug error was omission. And we also looked at level of drug error, where did the drug error reside, with patient or nurse or physician or pharmacy? PJ, I'll let you elaborate further.
Yeah, so as Mike said, omission was the most common error, but there was also a substantial number of commission errors where people have kept going with a drug they were supposed to stop. There was also dosing errors. When we look at where the errors occur, it most commonly occurs with the patient. And I think this is not the least bit surprising if you think about a lot of our elderly patients having surgery. They often come to surgery on lots of medications. Either some of them are being stopped, doses are being changed, new medications are being added, and then they're being sent home. And obviously this makes them vulnerable to having endless, problems that can occur. So about 3/4 of the errors occur at the patient level. However, 20% of the errors occur at the physician and nurse level in the hospital. Physicians either forgetting to write a prescription for a drug that they said that they want the patient to go home on, or failure to write a prescription to stop a medication and the patient then keeps taking it because the pharmacy keeps dispensing it. Only about 5% of the errors happen at the pharmacy level where the wrong drug was prescribed and where the pharmacy provided the wrong drug for what was actually prescribed. So that's uncommon, but it happens. And so I think, what this highlights is that, we need a system in place that is going to be thorough to help minimize patients having these errors. And I think it's not simple to do it if you don't follow up with patients when they go home. There's no doubt, if you look at a system like Epic at St. Joe's compared to HHS, is that Epic makes it better, but it still does not change the fact that there's still lots of errors we saw in drugs, even across centers that have Epic. because there's just so many drugs that a lot of these patients are on. There's so many changes happening. If you don't follow up with the patients very quickly when they go home, I think it is a foregone conclusion you're going to have a lot of patients with serious drug errors. And again, not all the drug errors are crucial, but there's no doubt there's some serious errors that happen where people aren't taking their anticoagulant for VT prophylaxis. They're not, going back on a serious medication like, their Plavix, whatever it is. All kinds of errors happen like that. And if we don't put in place a system that will quickly follow up on patients, I think we just need to acknowledge that there's going to be lots of drug errors.
PJ, you mentioned Epic, and Barry had a comment in the Q&A section, talking about the plugin for Epic and how, there'll be a patient portal with MyChart where, pictures can be exchanged, the potential for remote monitoring and virtual care directly through that portal. Hopefully that will facilitate those visits and exchange of that information. But I'm interested, because with Epic and all these EMR systems, there's more robust medication reconciliation on discharge. But you've alluded that the fact that having those systems actually do not, or maybe reduce. I don't know. Have that been looked at, the differentiating Epic from non-Epic centers, and you're analyzing your data?
Yeah. So again, I want to be clear. There is, I think, zero ambiguity. Epic is a substantial step forward because people are forced to do drug reconciliation at the time of discharge. That still does not mean, though, when patients go home, because they basically take those prescriptions to a pharmacy, the way that the current prescriptions are done, certainly in my experience working at St. Joe's, is that it's saying continue your old medications or stop an old medication, and here's prescription for the new one. But again, that's a lot to necessarily ask of someone who's in their 80s going home, that yes, the pharmacist may get it right, but it doesn't mean that when they get home, they're going to remember all that. And so there's no doubt Epic is better because it forces drug reconciliation, which doesn't happen all the time at our current HHS system. And obviously, I think there's no doubt with HHS moving to Epic, we will see improvements. But again, the problem is still ubiquitous because there's often just so many drugs that people get confused when they actually get home.
And Dr. Holbrook is Anne, do you want to speak up?
Yes, thank you. Thank you. I can't resist a comment, but I do have a couple of questions. So the comment is that with Epic, you have to have a very accurate home medication list to start with. Otherwise, it's garbage in, garbage out. So there's still a bit of trouble with the way the discharge prescription is presented. So it needs a bit of work. But my questions are two, hopefully quick. One is congratulations on having older people interact with technology. Our EMR trials 30 years ago failed basically because older folks would not interact with computers. So the first question is, what do you think are the pearls there? Is it keeping things, very simple or making it very important? The second question is, could you comment on this intervention would cost a fair amount because it is 24-hour care with health professionals. Do you have any data yet on cost effectiveness of this kind of approach in healthcare? Thanks.
Mike, do you want to go?
Sure. So, and thanks so much for your question. I think your reflection on the end user is really crucial in this type of work. And so, SMArTVIEW gave us an initial opportunity that was funded by a CHR program focused on implementation and process and user testing and integration of systems with EMRs. And so we did spend time engaged in detailed user testing that involved the patients to start. So we worked with seniors who had sustained postoperative adverse events, showed them different technologies, and spent considerable time thinking through a workflow that they felt would be, understandable and simple. And then we tested that with patients in order to get our approach to training and down well. And so, we had cameras focused on patients. They thought they would do think aloud and tell us, you're not being clear in the instructions, or you are. And from there, we gained a lot of experience in how to communicate about the technology simply and to eliminate aspects of technology that are too complex for patients. And so applying that, with our industry partners, the key that you said is simplicity is key. Large buttons, simple instructions, attention to pre-assembly, but also attention to structure that doesn't impose on patients. So for example, we use cellular enabled systems that do not require patients to interface with home Wi-Fi. So keeping it simple is critical. I'll pass to PJ for the rest.
Yeah, so I'll just say that, Anne, when we first started down this line of research, I remember thinking Mike was slightly crazy because he was convinced that, you know, every 90-year-old would go home with this. And I was trying to think, there's no way they're going to do this. And it is true that, you know, as we saw, there was, you know, some patients who don't do it, but it is actually shocking to me how many older patients use the technology and used it seamlessly and did a great job with it. But the key part is, like, we work with a lot of companies in this space. For certain, Cloud DX is the company in my mind that has really grasped the point. This has to be incredibly simple so that, you know, anyone could use this and it's non-obstructional. And importantly, like where we're going with this research, like what Vision 2 is going to be using and Vision Cardiac Surgery 2 be using is a device that basically you just put on the patient's chest, and that device can non-invasively measure patients' continuous blood pressure, heart rate, heart rhythm, 5-lead ECG, temperature, respiratory rate, body position. It can even give you sleep analyses, and the patient doesn't have to do anything, and they can wear it 24 hours a day. And so again, I think we need to get to a place where, you know, we're going to have smart enough technology that's in the background that's non-obstructional to patients and can give us continuous data. And in many ways too, this is also what we should be doing in the hospital. So in our research, you know, 10 to 15% of nursing time on surgical wards can be spent measuring vitals. 90% of the time it's useless. The vitals are fine. It's a waste of time. And 10% of the time, you're just showing up 2 hours late, actually for when the vital sign actually started to shift in the wrong direction. We should have smart technology that is continuously monitoring our patients in the hospital, and simply using AI will alert us when the pattern is becoming obvious that the patient's vitals is going in a direction that puts them at high risk for a serious event being identified in the next 2 to 3 to 4 hours. And I think that's where we have to go. But the key thing is, it's working with companies that get it. It has to be incredibly simple and unobstructional to patients, and that's crucial. You raise a great point about the economics, which is that it's not free. That being said, the economic analysis, because the cost of ER visits and readmissions especially are so expensive, that in fact, it looks really encouraging even with the initial look at the economics, but we're doing a full economic analysis. But I also want to highlight another point, is that, you know, like we've done lots of trials in the perioperative setting. There is no intervention for which in any of the trials I've been involved with, where we've had so much spontaneous comments from patients that we have to make this technology available for people in the future. And in contrast to what I thought, you know, when Mike was saying, hey, we should give this to 90-year-old, and I'm thinking there's no way they're going to use it. We had a situation where lots of 90-year-olds don't want to give it back at the end of 30 days because they have 24 hours a day access, you know, to a healthcare provider who will address their problem. And I'll just, a lot of times case, you know, like data is one thing, but cases tell a totally different story. We told you a case in the initial part of the presentation about an elderly gentleman and his wife choosing to let him sleep because he's tired, when in fact the patient's in complete heart block. But I'll share another one, which is not about life or death, but it actually highlights what is almost for certain everyone who's a physician would want for their loved one. So one week when I was on as the perioperative care physician, I get a call on a Saturday night, 9 o'clock, from a nurse saying there's a patient with a lot of pain who lives in Niagara Falls. This patient had had a urological procedure at the Jarovinsky 3 days before. Because we're following the patient and we have our patient profiles, I'm able to look at this patient and I know his full story in a matter of like 4 minutes. I then virtually am connected with the patient within 10 minutes seeing the patient. Patient and talking to him has 8 to 9 out of 10 flank pain going down to the groin, dysuria, frequency. So I diagnose, you know, UTI, likely pyelo. I'm able to phone this patient's pharmacy, order antibiotics, have the nurses send a rec to the life labs so the patient the next day can get an outpatient urinalysis. And this happens in less than 30 minutes at 9 o'clock on a Saturday night. Now, what's the alternative in the standard care group for your loved one? Well, the alternative is your loved one either deals with, you know, this pain and discomfort that night, or they choose to go back to a hospital in Niagara Falls where they didn't have their surgery, or they choose to drive all the way back to Hamilton to go to the hospital where they had their surgery. And in either of those scenarios, they're not getting out of the ER probably till 2 to 3 to 5 in the morning with the prescription for antibiotics. So the point I'd also just want to make is that, yes, it will cost money, but there's nothing for which I've ever been involved where patients felt so compelled that the experience was so profoundly different that people are also, they're zeroed out my mind, also willing to pay. But we also need to keep making the system more efficient. And I think by having better technology, we will actually need to, we can minimize the amount of nursing time per patient, but it'll still remain crucial that we need a nurse physician dyad, and we need a physician group who's available and engaged and wanting to be, change things, as opposed to, just say, okay, send them to emerge or let something else happen. So I think, there's lots more to do in the economics, but I actually think that this is still potentially a very winning solution for what will make patients' health outcomes and quality of life much more improved.
I like your comments, PJ, about economics. I mean, the cost is a very important corner of quality, but patient experience is super important, and even the provider experience. Think about with our hospitals being overwhelmed with patients, and we're at 120 and 130% occupancy. Everyone is exhausted. So it's great to be at home and be able to manage patients as well. So you're at home, the patient's at home. The cost is probably high, but it's not going to be higher than admitting and creating this bigger hospitals and more beds. So we need to start thinking about these virtual campuses that we have patients in. I mean, can we have these virtual hospitals with, rather than having occupancy of 120% inpatient, we reduce our occupancies and keep the patients at home and manage them from home. These technologies.
Helen, based on what you're saying, it reminds me too, just to mention one other point about the economics. PVC-RAM-3 is going right now. PVC-RAM-2 is about to start. And PVC-RAM-2 and 3, what we're also looking to do is we move randomization back prior to surgery. And what we're actually hoping to show is that, in fact, if the surgeon and patient knew that the patient will be able to go home in the intervention group with 24 hours a day, access to nurse and physician, and remote monitoring, we might be able to shorten the length of stay. So there's the whole issue post-discharge of preventing ER visits, readmissions, but we actually think you can back up the intervention and actually get people out of the hospital sooner. And importantly, we got to demonstrate that it's safe. But my suspicion is that most of us would rather be in our own home, but obviously to a lot of people, they only want to be in their own home if they know it's safe. Having remote monitoring technology, which you can in fact measure your vitals more frequently than happens in the hospital, because you're not limited by someone being available and not busy with another patient. You can put on the technology and measure your vitals all you want, and you have 24 hours a day access. So we're hoping that that's another part of the economic equation that we can explore, because it'll also help us address the huge backlog of people waiting for surgery at the moment. That's part of the goal within that.
Yeah, bed occupancy is high. Surgeries are canceled. Very important. I'm very interested in this discrepancy in escalation, and is it a matter of a human factor? I mean, in quality, we focus on standardization of care, and you've alluded to the fact that you brought your teams together. Is it about the individuals? Is it about the method of you bring your team together? I'm sure Michael probably have some comments on interprofessional communications and how that really impacted the care that was provided at different centers.
I think if we just step away from PVC-RAM and this virtual care research, I think the reality is we all see at times variation in how much physicians may be engaged in people's care. And I just think that at times, people are hoping that with the technology, great, let's get the nurse to deal with this on their own. And if you send the message to the nurse, why are you bothering with this? Then very quickly they stop letting you know about this. And again, it's why it is so crucial that there has to be this close dyad between a nurse and physicians who truly are engaged and want to be involved and want to actually make a difference in this, as opposed to, don't bother me unless someone's about to die. And I just think the problem is culturally we see this in different places. It happens. It's not that people are bad people, but it's people can be overwhelmed, exhausted, tired, and it's like, people send the wrong message, and then quickly that all of a sudden leads to huge variation in what you see in care. So I think a really crucial message is that if we expect to provide technology and the technology will solve the problem on its own, we're going to be very disappointed. You need a clear pathway of what is going to identify the problem and how it is going to be addressed and who's going to address it. And, you know, we need physician groups that really want to be engaged with this, because that's what's needed along with the nursing care.
Mike, do you have anything to add to that?
Yeah, I'll just add to that, that part of it too, from just an implementation point of view, if we reflect on the evolution of what we did, you know, in SMArTVIEW, the triggers that we developed had sort of a trend analysis over 2 to 3 days, and we borrowed from chronic disease management using virtual care because it was early work. In PVC-RAM-1, we sat, reflected on lessons learned, and developed those triggers and thresholds. And that's still an evolution in our learning about where to get that right. And so part of it too, we're talking about, you know, behavior change and workflow is constant attention to change management and communication within your teams, implementing these interventions that, you know, these triggers, you might feel some of them are noisy, but we're using it for now because we don't want people to slip through the cracks. So keep giving us feedback. So it's really important to have those open lines of communication where we're continuously reflecting and clear instructions. And so, you know, as PJ said, in PVC-RAM-1, we allowed people to adjust the thresholds because it was still new to us. And now we've learned that the thresholds that we have at minimum are really important so that people don't slip through the cracks. So there's a lot of work to get people engaged and thinking about these things and the behavior that is required to execute the protocol. So it's an important part of these more complex interventions.
Thank you, Mike. So I think we're at time. Thank you, Dr. Devereaux and Dr. McGillion, for sharing this excellent results with us, and congratulations for the success so far. And we'll look forward to learn more about the post-operative and perioperative monitoring and the use of technology and to improve, you know, patient care and patient experiences. So thank you very much, and I wish everyone a great day.
Thanks so much for having us.